Thank you very much, Maya, for this presentation on the role of community compensation intervention in reducing stigma related to lower limb and lymphedema in North Ethiopia. Last but not least, we'll be hearing from Professor Ahmed Fahal. But before that, I'm delighted to announce that he has received a reward, a certificate of appreciation from the NCI. So I think deserves a round of applause for that. And after this presentation, we'll be taking a photo with DNDi to celebrate this award that you've received for your fight against mycetoma. And you will specifically be talking about mycetoma, disabilities and stigma, innovative thinking, out-of-the-box solutions. Thank you, Professor.
Hello. Thank you very much, Stephanie, for offering you a seat to be very close and cozy to the presentation. Mr. Chair, ladies and gentlemen, it is a pleasure and honor to be here in the first ever WHO Skin and Disease Global Meeting. This is Sudan, this is Khartoum, and this is the junction between the White Nile and the Blue Nile. My name is Professor Fahal. I'm a professor of surgery at University of Khartoum, Mycetoma Research Center, the WHO Collaborating Center on Mycetoma. I'm going to talk about mycetoma, disabilities, and stigma, and to share with you some of our thinking out-of-the-box solution to these. I declare no conflict of interest in this presentation. All photos, images were taken after informed consent. The main objective of this presentation is to share with you experience on mycetoma, disabilities, and stigma, and to share with you some of the solutions invented by the Mycetoma Research Center, Sudan. And this is the outline of my presentation. I'm going to talk about mycetoma as a social, medical disease and a problem, and some of the intervention we did, and to share with you some take-home messages. For those who may not be able to stay to the end of this presentation, I'm going to conclude by saying that mycetoma is a scar in the human conscience. And our job is to heal it because it is non-glorious disease. Ladies and gentlemen, mycetoma, it is a chronic ladies and gentlemen, mycetoma, it is a chronic disabling disease characterized by massive deformities, destruction, and loss of function, and loss of life in some of patients that come late. You can see it can be very aggressive, as in this poor gentleman who had a blown-knee mycetoma, ended in above-knee amputation, recurrence in the stomach, and it had spread to the anterior abdominal wall, intra-abdominal cavity, and affected his urinary bladder. You can see how massive the mycetoma deformity can be, and you can see in this patient with actinomycetoma, amenable to medical treatment, how massive the disabling, figuring, mutilating disease. That should be a very clear treatment for this patient and outcome. Sadly, about 30% of our patients and you can imagine the misery of these young chaps with a patient and this patient with a head and neck mycetoma. Mycetoma is associated with a lot of disabilities, difficulties, constraint, and amputation is an important cause of social stigma, poverty, and ignorance. For a female, it can put her at the end of the road. No social life, a lot of difficulties in dealing with things. Mycetoma can be as massive as this, and the treatment can be as massive as this. And this is a total lower limb disarticulation for a mycetoma not responding to medical treatment. And here, even you can see the disease has spread to affect the intra-abdominal cavity and other structures. Mycetoma in endemic villages can run in families, as in these 4 members of the same family. All of them had mycetoma, ended in amputation. Mycetoma can be a big burden on family members. This chap has left his job overseas to come back to Sudan just to support this poor patient with amputation and mycetoma. And again, we have to remember that it affects the poorest of the poor in poor communities. These people, they use a self-made prosthesis, difficult to use, and it's hard to move around with this. Most of them, they had an old broken prosthesis like this. For this, the Mycetoma Center had come with some ideas and interventions to deal with these patients and their problems. One of them it is to establish 2 peripheral satellites for mycetoma patient care. We did a lot of field surveys. We appointed many community activists and social workers as ambassador for mycetoma. We established the Mycetoma Patients Friend Association to help these patients and to help themselves. Also, a lot of health education events and activities, and we engage ourselves with many fine artists in the country and overseas for advocacy of mycetoma. Furthermore, we work on the processes, the campaigns. As part of the holistic management of mycetoma patient, we had animal cage construction, and we have a social media activities, and we have the Mycetoma Vocational and Entrepreneurship Center side community engagement activities, and that done in line with research. This is one of our satellites in one of the endemic villages where we see patients there, and we deal with them. The whole team of the Mycetoma Center moved to the village, spend few days there, and do the surgical intervention and other activities free of charge. In the villages, we do a lot of surveys using our TAPI. This is an application to collect data. And here you can see one of my colleagues doing ultrasound examination in one of the villages at midnight using a mobile torch. And this is one of our lab technologists dealing with a biological material, again, you can see the torch of the mobile to have a light to do these things. A lot of problems, mechanical difficulties, roadblocks, these are the constraints we face during dealing with this patient in the field. In the field, we did more than 1,000 surgical operations and more than 1,500 ultrasound examinations free of charge for these patients. Again, that had led to reduce the number of patients coming with massive mycetoma. Most of them, they're coming now with a small lesion, and reduce the number of amputations among these patients. One of the solutions to deal with the problems of the mycetoma, stigma, and disability, we established sites.
Mycetoma is a neglected disease that affects parts of Sudan, especially rural areas where people live with a low economic level. When the treatment of mycetoma is delayed, a lot of patients become completely or partially incapacitated due to amputation of their limbs, which causes them economic and social problems and leads to the loss of their jobs. The Mycetoma Research Center provides treatment to patients, communicates with them, and organizes awareness and treatment convoys to their areas. The center found that there is a need to provide social and economic support to patients to help them after receiving treatment. Thus, we established the Mycetoma Vocational and Entrepreneurship Training Center, SIDE. SIDE Center provides training to acquire knowledge in the fields of sewing, carpentry, horticulture, leatherworks, pottery, foods, and others. To deal with the mycetoma amputation, we are now collaborating with one of the incubators in Khartoum, established by young pioneers to develop a new processes for these patients that can be easy to be used and light for them. And this is one of the patients with amputation of the hand and using these prostheses, using his shoulder girdle muscles to move the fingers in these prostheses. As these patients cannot come from the rural areas to Khartoum and big centers for the prostheses to be done for them, we moved this mobile workshop to one of the villages where we did more than 160 artificial limbs for these patients and to complete their life journey. As we are dealing with this patient in a holistic approach, we managed to have these new animal cages for them to reduce the contact between the animals and the patients and the people and to reduce the number of patients. We established a state-of-the-art Mycetoma Media Center, and this center is very much active in producing material for advocacy and awareness. We have now more than 120 video films, clips on mycetoma advocacy and awareness. We appointed many active member societies as mycetoma ambassador, and here you can see this is the top celebrity in the country, part of our group. They established what is known as We Are With You, and these are the 40 top celebrities, comedians in the country coming to the center, singing and talking to the patient. All these done under the research activities. We have a lot of research going on right now on the social impact of the mycetoma, economical impact on mycetoma, and we are now using artificial intelligence for more diagnosis accuracy for mycetoma. Mr. Chair, ladies and gentlemen, in conclusion, I have to say that Mycetoma Center in Khartoum is dealing with unique patients. We have unique diseases, and they have unique problems, and our job it is to find a unique solution for these patients. I am very grateful for our patients, the community, for helping us to helping them, and they are very grateful for what we are doing. And thank you very much for your kind attention.
Thank you very much, Professor Fahad. Thank you very much. Many moving images that show the distress that all these people have to go through. Now we're going to open the floor to questions and the discussion. I'll give the floor to my colleague.
I have a question for Dr. Wien van Brakel. In your study, there is clear that the disability and the mental health disabilities, it's more in the leprosy group. Is it related to, in your opinion, is it related to the disease, or because in the group of leprosy there is more severe disabilities in the groups?
Thank you for the question. I think it may be true that, relatively speaking, the people in the leprosy disabled group had more severe disability, although the absolute numbers of people with severe LF-related lymphedema were higher in the two districts. But I think since there is a clear link with stigma, it is probably the fact that the stigma is more severe against persons affected by leprosy, and even the self-perception, as we saw, the internalized stigma, the anticipated stigma is more severe on the side of persons affected by leprosy. So I think that is probably a main reason for that. We have done also multivariate analysis, but I didn't have time to show that.
We have a question that was put to us online for Mr. Anabilian regarding the redress project.
Obligation to not refer patients to the formal health services, or is it more about money? Voilà. Anabilian, est-ce que...
Anabilian, are you here? Are you online? Could you take the question, please? Thank you. Thanks. You have the floor.
Thank you very much, Mr. Chair. My question is to Professor Fahad. First of all, thank you very much for the inspiring and fantastic presentation. Would love to have a copy of that. Yeah, and my question, although, I forgot to introduce myself. I'm Kazim. I'm the regional team lead for neglected tropical diseases for WHO's Western Pacific region. My question is more on the prevention side of mycetoma. As you mentioned that mycetoma is primarily a disease which affects people in hard-to-reach areas in Sudan and the most impoverished people. So given that context, if you can tell us a little bit more on the prevention, what other than the animal cages and having ambassadors and all these advocacy videos, what specifically you are doing within, keeping in mind the context of those people, who are extremely impoverished? Thank you.
Oui, Professor Fall.
Professor Fall, the floor is yours.
Thank you very much for this. Actually, it's a very difficult question because still we are not very sure on how the infection is taking place. There is a lot of gaps in the epidemiology of mycetoma. We know that traumatic inoculation of the causative organism into subcutaneous tissue may be the root of infection in this patient. And that is why made the prevention and control program very difficult. Right now, what we are doing early case detection and early case management to avoid patient coming late with very advanced disease and deformities and amputation. So that is why now we're having these satellite centers in peripheral areas where mycetoma is endemic. We have to go to the patient there, not let them come to us in the big centers, and to do the surveys, trying to find the patients at an early stage and to treat them. This is the main issue right now. Because if you wait for them to come to you, they will come late with very advanced disease, as we saw. So now we are in these centers, we are seeing them. We are trying to convince them to have the surgical intervention as early as possible, and all this done free of charge because they cannot pay for these things. So early detection and proper management and diagnosis are the important issue right now we are dealing with. We are still very far from having a very clear control, prevention, elimination, eradication plan for this patient. Thank you very much.
Merci beaucoup.
Thank you very much. Dr. Ronaldo, did you want the floor? Please.
Mr. Chair. Seeing Dr. Van Brakkel's presentation, looks like there was some sort of a lack of a gender equality. And I'm wondering, and this question is for all of you, are you using some specific language or tactics to achieve gender equality? Thank you.
Thank you for the question. I'm not sure how, from my presentation, you concluded that there was no gender equality, because there was equal inclusion of men and women in this study. And I think what we also showed was that we looked specifically for differences in experiences between these two genders. It is true that sometimes instruments may need to be adapted, or the approach may need to be adapted depending on the gender and sex of the respondent. What we have, for example, in this tool called the social distance scale is a verbal vignette which paints the picture of a typical case of either leprosy or lymphatic filariasis, and then that vignette is not only adapted to the condition, but is also adapted to the gender of the respondent. So that is one example of how that is done.
Thank you very much. I see another hand up here. Thank you. Go ahead.
Oui, merci, Monsieur le Président.
Thank you, Mr. Chair. I wanted to comment or add something to what Professor Fahal said. I am the focal point for mycetoma at the regional office at WHO, AFRO, And I wanted to say that the issue with mycetoma is that it is an NTD that was added recently to the list of NTDs. And there's a serious issue in many countries regarding the mapping of this disease. Certain countries have declared that they don't have this disease while it is present. So it is an issue that we are currently working on for several purposes, for the mapping, in order to raise awareness, health staff and governments, in order to set up and implement a strategy at those three levels with the WHO. Thank you. Thank you. Indeed, we do need to implement a surveillance system in order to detect and get information and deal with this issue. We have a request that has come in online. In the room, is there a specialist?
President.
A specialist on rehabilitation? A specialist on snake venom, excuse me. Do we have a specialist in that field? Thank you.
Oui, voilà, c'est ça.
Réhabilitation ou
Voilà.
envenimation?
Est-ce qu'il y a des interventions transversales qui sont...
Are there any cross-cutting implementations that have been done in terms of snake venom?
I'm not sure if she's here, but Professor Imke Stienstra was in the meeting, and she is working with the Liverpool Tropical Medicine on snake envenoming. But there was a BU meeting
Est-ce qu'il y a quelqu'un qui peut répondre à cette question parmi les...
Can anyone take this question? Thank you. Dr. Daniel, you wanted the floor?
Thank you, Mr. Chairperson. Mine is a question to Professor Fahal. Thank you for your very interesting and enlightening presentation, as usual. And also your good work at the same time, I appreciate. I have a couple of questions. One is about the incidence of new cases of mycetoma. Because we don't see the trends, we don't have a good surveillance system globally and also regionally. How is the incidence now? I know the prevalence is increasing because of the number of chronic cases and the long duration of treatment, but do you see any change in the incidence over the past years, especially as interventions are intensifying to address the various known risk factors? Of course, there was a plan also to do a more comprehensive risk factor assessment. I don't know if that was completed. This is one question. So my second question is, there is this study going on also to improve the treatment duration and the treatment outcome. It could still be at a preliminary stage or advanced, but if you could also highlight us, give us some information as to the status of this study. Thank you.
Thank you very much, Daniel, for the important question about the incidence. Actually, the incidence is increasing because now we're going to the field, we're seeing patients in the field, we're doing active case retention, active case detection, and management of these patients. So definitely the incidence is increasing. The good thing that we're now seeing patients with a small lesion, amenable to treatment with a good outcome. This is the good news about what we're seeing in the field at this site. As you know, still there is no international, the number internationally is not well known for the incidence and the prevalence. Regarding the treatment, I have to say I'm very grateful for DNDi, Geneva, for supporting the first ever double-blind clinical trial on mycetoma treatment. The trial took about 5 years. It's finished now. Now we are in the stage of analysis of the data and writing up the paper on this. The good news that the new drug, it will be a very good drug because it will be taken once per week. Will be very handy and acceptable by the patients, and the compliance will be much better for the what is available right now. Right now, what is available is itraconazole, 4 tablets per day, which is a very big hurdle on the patients and the family and the health authorities in endemic areas. The new drug will be taken once per week, and that is a big plus for the patients and the community, as well as the health service and the system, because it will be definitely more economical for both the patients and the health system as well. But it's very encouraging, and the results are very good, I think. Thank you very much.
We still have a time for a few other questions, please. You have the floor.
Bonjour.
Good afternoon. I'm Anthony Lixton from the International Alliance for Albinism. And I have a question regarding the session this morning. I heard about the impact of disease on patients. I heard about the importance of holistic approaches. We also discussed people-centered approaches and the importance of involving associations of patients. But we did not mention human rights. We are, of course, patients, but we are also human beings. And, of course, we aspire to optimal health in physical and mental terms, and also our human rights. So that means that we have the right to health, education, work, non-discrimination, etc. And our well-being and the quality of our life depends on all these rights. So I have a question regarding the importance of involving other parties in our work, in particular other UN agencies and organizations and experts in the field of human rights. Thank you. Thank you very much for bringing this up. In order to make the best of the time we have left, we are going to take a few questions and then respond to them. There's a question here, one on my right here, and one on my left.
Okay. Merci, Président.
Thank you, Mr. Chair. I am Dr. Ngissa Madi from the National Program to Combat Buruli Ulcer in Ivory Coast, and I have a question regarding Mycetoma. I thank the speaker for his presentation. Now, what I would like to know is regarding the treatment of patients, Mycetoma patients, treatment they are currently using, regarding the molecules and in the field before clinical trials yield results. Is there a molecule that can help to mitigate the imputation rate among patients that suffer from this deep mycosis? Thank you. Thank you very much. Thank you, Professor Fahal, and thank you for the presentations. Yes, the photographs speak for themselves. And we thank all the health workers that are trying to care for these patients. But of course, public health always has to take a step back because, as you know, we don't have enough data. And we have, the most data we have is actually in Sudan. And in order to implement primary policies. So are you working with epidemiologists in your centers that who could provide a maximum of information regarding these patients and mycetoma? Thank you. I also saw a question on this side. Yes, please go ahead.
Thank you, President. I have also a question for Professor Fahal. I'm Professor Jean-Pierre Gagneux from Rennes University in France. And my question is regarding diagnosis, lab diagnosis. Of course, it's very important to distinguish mycetoma due to fungi and mycetoma due to actinobacteria. So how can we improve the diagnosis of this disease? Because this will drive the treatment. Thank you very much.
OK, donc nous pouvons...
Très bien. Sorry. Very well, Professor Fahal. We have 3 questions that were addressed to you, and the floor is yours.
Mr. Chair, regarding the treatment of mycetoma, as you know, we have 2 types of mycetoma. We have the fungal type and the bacterial type. The bacterial type is amenable to treatment by a combination of antibiotics. And the results are so good, but it takes quite a long time, and that is why you have to look for new antibiotics that can treat the patient in a very short duration compared with what's happening now. For the fungal type, it is a big problem because still there are very few antifungal drugs susceptible to be used for these patients. Currently, we are using itraconazole as a treatment of choice for 6 months, followed by SEDIC intervention, and another 6 months with antifungal, trying to reduce the incidence of recurrence and the other problems. Regarding the new molecules for the treatment of mycetoma patient, I am glad to say one of my PhD students in Tours University now, she is coming up with more molecules that can be used in the future as a drug for mycetoma patients. But right now, we are using this pre-purpose drug for mycetoma patients. The diagnosis of mycetoma, currently, it is a bit tedious. It is a long process, and it needs a lot of experience and equipment. The standard treatment, the standard diagnostic tool now, it is the molecular diagnosis for mycetoma patients. And I'm glad with our collaboration with Erasmus Medical Center now, we are coming up with more primers to be used for this diagnosis, for this organ to be diagnosed in the lab. We're having an ultrasound diagnosis, cytology, but still looking for patients for more collaboration for having a point of care test. Currently, we are working with 4 universities in Japan and Netherlands to come up with a point of care test for mycetoma patients so we can be able to diagnose the mycetoma patient at the level of the field. Thank you very much.
Thank you very much. This is a very interesting discussion, but the session has reached its end. And I think that all the presenters deserve a round of applause. And now, as I announced, I would like to invite the DNDi team to come and join me along with Professor Fahal. Please come here. Please come to the middle of the room. I'd also like the participants to come closer so that we can take a photo with Professor Fahal. Please.
Venez. Voilà.
Everybody come.
Oui, please.
Please, everybody come. Yeah, come. Just come and stand in the background. Yeah.
Oui, je crois que ça marche, non? C'est bon? Ça marche? Hein? Non, ça marche ou pas? Non, ça marche pas. Oui, ça marche. Ça marche là? OK. Yeah. Let's not cry, huh? Okay. You mustn't cry. So I'd like, this is a very important moment for Mycetoma. For us, with many of you, we managed to add Mycetoma to the WHO NTD list. This was in 2016. It was a very important moment for some of us. Look at Professor Fahal. And 7 years after, we are here to celebrate the fact that one landmark clinical trial was conducted with the Mycetoma Research Center, with many partners, with support from the NTD.
Unfortunately, the interpreters cannot hear the speaker.
On behalf of the Mycetoma patients, their families, and their communities in remote areas, I would like to express my sincere thanks and gratitude to DNDi for supporting us to support the patients. The DNDi has made a lot of effort to make the Mycetoma known to the international communities, to the international research centers and institutes, donors, and funders. The NTD had a lot of effect on our work in the Mycetoma patients' activities. The NTD had supported the first ever double-blind clinical trial for Mycetoma treatment. The NTD had trained us to do a proper clinical trial. I was trained by DNDi in doing a proper research for these patients. We have the best ever lab for Mycetoma diagnosis supported by DNDi. DNDi has supported us to establish the peripheral satellite centers, the labs, the ultrasound machines, and other activities in the field, the trips, and the campaign to see patients at the level of the field and to treat them there. The NTD has supported a lot of my colleagues for training in good clinical practice, laboratory practice, and even in financial practice, and how to conduct and to administrate a proper clinical trial activities. I cannot say how we are grateful in Sudan for the NTD for making us coming to this point and be here in the WHO today. And without the effort done by the NTD, I was not be able to come to this. I'm not able to come to this event and to be part of this community of researchers. Definitely, the DNDi had impact on not on Sudan, on different people in different parts of the globe with affected with Mycetoma and other neglected tropical diseases. Currently, we are having 3 projects with DNDi running nicely, smoothly, and I'm sure the result will be of great help for the patient and the communities and the health system where Mycetoma is endemic. I'm very grateful for this lady. I call her the mother of Mycetoma because she is the one who put the Mycetoma in the agenda of WHO priority list and the DNDi agenda as well. So thank you very much for this.
Thank you. Thank you. This is really a very touching moment. I really appreciate the NTD colleagues for thinking about this award and recognizing Professor Fahal in this occasion. We are also delighted. We didn't plan it. It was not in our agenda, but it's a surprise, but a nice surprise. Really, thank you. The Mycetoma Center, Professor Fahal has been, an outstanding and passionate person with regard to his center. He has met and advocated for the cause of mycetoma and for those horrible, disease and for those patients affected by this horrible disease for a long time. The first time I went to Sudan for a leishmaniasis mission, he took me from the WHO office to show me in the Mycetoma Research Center and take me around, to see how, this patient, this community are affected by this very bad disease. So he has advocated in all international forums. He has sent all his books and all these, pictures to all directors of the NTD department before mycetoma was recognized. Thanks also to the support of the MSF and the NTD colleagues who helped a lot, advocated a lot for making mycetoma a global agenda. Now, since 2016, mycetoma has become a global agenda. Since then also, a lot of progress has been done on the clinical trials. Recently, we have developed the target product profile, which may address the question from Professor Jean with regard to the diagnostics needs to differentiate actinomycetoma from eomycetoma. So we really appreciate your service as a WHO collaborating center, and also the Mycetoma Research Center is not providing care only for patients in Sudan, receiving patients from Ethiopia and other neighboring countries, even from Chad. So that is really appreciated, and it is the only center that is keeping a registry of all the patients treated in the center for so many years. So this is also another exemplary work. And the center is providing and supporting WHO in rendering clinical case management for countries even outside of Sudan, like Pakistan and etc. So we appreciate your service and contribution, not only nationally, but also regionally and globally. Please continue, and this reward is well deserved. Thank you.
Come to the center for the last photo.
Daniel, we need you.
Whoever wants to join, please join. Celebrate me.
Thank you.
Merci beaucoup.
Thank you very much.
Thank you so much. It was just, on a trouvé l'occasion, on s'est dit, allez, parce que c'est vraiment...
Nathalie,